Welcome to the Ellyn Satter Institute webinar, Raising Children with Special Needs to be Competent Eaters. I'm Carol Danaher, a clinical faculty member of the Ellyn Satter Institute and public health nutritionist in Santa Clara County, California. The Ellyn Satter Institute is a not-for-profit organization formed in 2008. The Institute devotes itself to passing on the legacy of Ellyn Satter's feeding dynamics and eating competence model through education, training, and research. If you find today's webinar helpful to you and you would like to support more programming like this, please support us by making a donation. You can find a Donate tab on the home page. We've changed the order of the three presentations in order to give adequate time to the case studies. Today, Ellyn Satter will present background information, and Pam Estes will present the G-tube-fed toddler with multiple health conditions. Next week, Ellyn will again start the session, and Dr. Ines Anchondo will present the poorly eating and growing child with Down syndrome. May 10th, our last session, Ellyn Satter and Ines Anchondo will present on developmental principles as planned. The order of the presentations have changed, but not the content. Our speakers today are both highly experienced clinicians who have volunteered their time to bring you this series of webinars. Our first speaker, Ellyn Satter, hardly needs introduction. She is an internationally recognized eating and feeding authority. You probably are here because you know her work. Pam Estes is a registered dietitian and clinical faculty member of the Ellyn Satter Institute. Pam has worked with Ellyn's feeding dynamics and eating competence models since 1996. She applied them within Indiana's early intervention program, offering nutrition services to children with special health care needs for 6 years. Thank you, Ellyn and Pam. We are offering a certificate of participation available on the Ellyn Satter Institute webpage. We will email you a link to the certificate of participation after the third webinar. Ellyn, I'm turning this over to you now.
Thanks, Carol. I am going to do my chore here. Okay. These webinars seem like they ought to be easy, but they are more tricky than they seem like. Okay. We have liftoff. Hi, everybody. Welcome to our second ESI webinar series. We seem to be following the trust model in presentation, as Carol told you. We got into our content and we found that these case studies were just so rich that we couldn't and didn't want to squish them into a single session. So as a result, we'll have one case lesson this week and one the next. I'll begin this week's session by talking about assessment, and the case lesson is by Pam Estes. Next week, I'll begin by talking about treatment, and the case lesson is by Ines Anchondo. The feeding dynamics model is a synergistic combination of parent leadership with feeding and child autonomy with eating. Within a positive feeding relationship, children's natural capabilities with eating emerge. Whether the child is well or ill, this starts with the child's earliest days. The feeding dynamics model is based on the division of responsibility in feeding. In infants, the division of responsibility is simple. Parents get to choose whether the child should be breast or formula fed. After that, it's all up to the child. How much, how fast, how often, at what level of skill. The parent's job is to calm and organize the child and feed in a smooth and continuous fashion. You're likely more familiar with this version of the division of responsibility in feeding for toddlers through adolescence. Embedded in the division of responsibility are some assumptions. The parent is the gatekeeper with food selection, takes charge of the schedule with meals and snacks, makes eating time pleasant, mostly by sitting down and eating with the child, not just feeding her, and showing the child what to learn, and of course accepting and supporting the child's natural growth potential. Many people who like the division of responsibility put the word healthy in here, and it just doesn't belong. because the insisting on healthy food is likely to act as a deterrent for parents in getting meals on the table, and regular meals are essential to following the division of responsibility in feeding. The key word here is trust. If we do our jobs with feeding, children do theirs with eating. You can only observe a division of responsibility in feeding if you absolutely trust the child to determine what and how much to eat of what has been put before him by adults. This is a summary of the division of responsibility in feeding. Cleo has posted the handouts on the ESI website, but I also want to show you where it is here on the Ellyn Satter Associates website. You see there's a division of responsibility in feeding and one in activity, and here is the division of responsibility in feeding. You may reprint that and use it in your own practice as long as you don't change it and don't charge for it and use the copyright statement. Children with special needs eat to the best of their ability and play an active role in feeding to the greatest extent that they are able. Children develop eating competence starting with their earliest days. Part of the artistry with feeding the child with special needs is providing every child a positive early learning experience. Pam will be telling you about Joseph, and Ines will be talking about Luis. Addressing feeding problems with these boys and with other children with special needs is complex. A careful and detailed assessment is necessary to sort out the complexity. These guidelines are on my website, and this article is one of your webinar handouts in the ESI, on the ESI website that Cleo just showed you. Let's see, on that, there you are, webinar handouts. And here is the assessment of feeding and growth problems, and here's treatment of feeding and growth problems. It will help you with next time's session if you can scrape out the time to read those two appendixes. They're both pretty short. Here's the organizing logic for the assessment. Now this logic is really important because it's quite different from what you use with the standard assessment. And that in the standard assessment, you usually, of the child with special needs, you tend to look for and emphasize deficits rather than capabilities. Here's the working hypothesis of the assessment from the feeding dynamics perspective and the overarching theme. Too often, addressing feeding problems is done piecemeal without a full understanding of what the child and the parent have been through. To repeat, all of these factors come into play with feeding problems. However, no matter what the primary source of the problem, the feeding relationship is affected. In fact, feeding dynamics is the overarching consideration in presenting and resolving feeding problems with any child, but particularly with the child with special needs. As we'll find in our case lessons, growth data reflect the child's physical and psychosocial history. Parents are helped enormously by our understanding what they have been through and how feeding problems have developed over the months and years. It helps them to replace their perception of their child as ill or handicapped with the perception of their child's capability. Of course, we must be also sensitive to the child's ongoing challenges. At times, distortions in nutrition and food selection contribute to the child's seeming incapability with eating. To avoid putting pressure on the feeding intervention, the child must have the nutritional reserves to withstand treatment or have an alternate place to get nutritional support, such as G-tube feedings. You can't both be teaching a child how to eat and be responsible for helping keep him alive. Applying the feeding dynamics model requires consistency, steady nerves, and a leap of faith. Will parents be able to do all this, or will they not? This question provides a litmus test. Pam's mother required secondary intervention, and Ines's mother required tertiary. To what extent has the child's accomplishment of developmental tasks contributed to her capability with eating? Conversely, to what extent has poor feeding practice contributed to the child's failure to achieve developmental tasks? This is a different slide from the last one I just showed. Is feeding consistent with the child's stage in development? This doesn't have ages because children with special needs have their own tempo for moving through these stages of development. Or I would say particularly have their own tempo. Every child has his or her own tempo. Parents will tell you about the child's behavior and limitations with eating, but they can't possibly tell you about their own behavior and limitations with feeding. Once you have all the information, summarize by giving specifics about each of the areas of assessment and be prepared to share that summary with other people who are sharing in the care of the child, including the parents. This is the general action-oriented impression, as is this. Which prepares you to talk with the parents, reconstructing the child's history in light of the presenting complaint as a basis for treatment and follow-up with the parents. Pam and Ines will apply these guidelines. And they'll tell you what this means, especially the bit about the child's jobs. And then you're ready to get a contract with the parent or agree with the parents can agree or not agree that they want to go ahead with the treatment you recommend. And then you set up your weekly sessions or your regular sessions as parents can manage. Focusing on their ability to institute and maintain division of responsibility in feeding, heading off pressure with feeding, giving support for doing the scary thing of reassuring the child she doesn't have to eat if she doesn't want to, and helping the parents to see that the child's eating is getting better in small, strange, and virtually undetectable ways. So Pam, it's over to you.
Thanks, Ellyn. Well, here is Joseph. I met Joseph when he was 12 months old. Here he is at 18 months, and he is eating butter. Joseph's very first phrase was, butter. But I'm getting ahead of myself. I provided nutrition services to Joseph's family through our state's early intervention program twice a month for 12 months. Starting with the assessment, we'll look through it together. Now, in order to do a thorough nutrition assessment, I reviewed medical records and growth charts from birth, as well as information from the individualized family service plan. This is how the referral read from the state's early intervention program. Joseph had hypertrophic cardiomyopathy. That meant he had an excessive thickening of the heart muscle and an abnormal muscle cell alignment. Basically, what it all ended up meaning was that Joseph had an enlarged heart. He had tracheomalacia, softening of the cartilage of the trachea. He presented with low tone. He had a gastrostomy tube, and the parents wanted him to eat. Now, as Ellyn told you, we work from the premise that given appropriate support, children will eat the amounts needed to grow in line with their unique genetic possibilities. If they don't, we ask ourselves, what is getting in the way of their doing so? In Joseph's case, his heart condition and his soft trachea both contributed to his inability to manage that tricky business of coordinating sucking, breathing, and swallowing. As you will see, multiple feeding methods were attempted to support growth and nutritional status. It took 10 months for Joseph to be nutritionally stable enough to begin to realize his inherent eating capabilities. I met Joseph and his mom when he was 11 months, 23 days, almost 12 months old. You can see here some of the particulars of their very rough start.
It says join webinar, and it says click run.
Oh. Is anybody else hearing that?
Yeah, I hear it.
Okay, well, I'll just go on. The exertion of eating overcame Joseph's ability to consume enough calories to grow predictably. They tried feeding on demand.
Go to the meeting, download help.
And then nasogastric feeds.
Right.
But
then when I do it, it says the webinar session should start in a few seconds.
I'm wondering if there's any way we could do away with.
I am trying to diagnose the problem, Pam. This is Cleo speaking. I'm trying to diagnose the problem, but I'm not seeing it here.
All righty. Well, I know you're a great diagnostician, so I'll just leave it in your capable hands. And as much as you can, I will talk louder so I can be heard. Okay, so as you will see, you know, they tried many different ways of feeding. They tried feeding on demand, even breastfeeding for a short time, then the nasogastric feeding, but Joseph didn't tolerate the NG feeds very well, and the gastrostomy tube was inserted at 10 months. Joseph was in and out of the hospital throughout the first 10 months, and it was during a bout with that very nasty RSV virus that the diagnosis of hypertrophic cardiomyopathy was made.
You know what I mean?
This is what I gleaned from Joseph's medical records and the replotting of his growth charts from birth. I'll give you a chance to read it, then I'll show you on his growth chart. So here we see his growth charts, and if we look at weight for age, you'll notice that he was growing predictably at the 50th percentile. But after about a month, he started to drop down to the 25th, then down to the 5th, and then below the 3rd. Length maintained for a little longer, but then once again it started to drop. And all of his growth then is in this uncalibrated area beneath the growth chart's percentiles, which really tells you nothing. Here's where I came in. Just to let you know, these are all my measures right in here. But as I said, this uncalibrated area really doesn't tell you what you need to know. And so for that, we turn to z-scores in order to get an idea of how growth proceeds for an individual child. These z-scores, or standard deviations above, or in this case below the mean, is how we can determine how growth is proceeding. Now here we see Joseph's weight for age z-scores, and you can clearly see the magnitude of the drop. in his weight during those early months. His birth weight was up at the mean, which is a 0 Z-score. And then by 6 months, you've got him down here, you know, greater than 2.5 standard deviations from the mean. And before you get too concerned about thinking about what Z-scores are, I want to point out to you that you do have a resource for that. And Ellyn's going to show you where to find it.
Okay, I'm on the Family Focus newsletter, and then here it is in February 2012. Okay.
There you go. There you go. So you can check that out later. At 6 months, we begin to see a bit of a more positive shift. With G-tube, at 10 months, growth begins to pick up appreciably for the very first time. And when Joseph was 6 months of age, occupational therapy, speech therapy, and developmental therapy all met with him and his family to determine eligibility for our state's early intervention program. So I reviewed information from the individualized family service plan, and here you see where the delays were found that made him eligible. The main concerns were related to feeding and motor skills. He was noted to have low tone in his oral structure, a minor asymmetry in his cheek muscles, his right cheek was larger than the left, and a high, narrow palate. These delays resulted in his being eligible for services. At first he received OT and PT 2 times a month, but within a few months both increased to one time a week. Now between 6 and 12 months he made strides physically, being able to sit independently and increasing the duration of nipple feedings before needing a rest. OT reported that his consumption rose from 1 ounce to 2.5 ounces before resting. He took no interest in the spoon, however, when it was first offered at 6 to 7 months, but by 11 months he was beginning to open his mouth for the spoon. OT observed, and this is a quote, "He eats best for mom. He doesn't like the oral stim exercises with the nuke brush." Now from the feeding dynamics perspective, we believe that children don't eat for others. They eat for themselves. And then during my assessment, when once again was around 12 months of age, I found his feeding skills to be in the 5 to 7 month range. Inherent in programs that determine eligibility for services like WIC or early intervention programs is the need to assign risk. Obviously, we want to make services available to those who most need them, and certainly Joseph did. Assigning risk, however, labels a child as different from normal and plays into parents' understandable fears and lost expectations. Is their child normal? Can he ever lead a normal life? And then comes the inevitable need to meet outcomes and the desire to overcome delays. All of these things conspire to put pressure on health workers and parents alike. It can seem that the most important outcome is to simply get the food into a child. But pressure on feeding undermines a child's autonomy, which ultimately makes him eat less well. As you will see, despite her own point of view, which included all of her concerns and all of her dreams for her child, Joseph's mother was also able to see things from Joseph's point of view, but she needed some support to maintain that stance. By the time I came into the picture, Joseph's behaviors indicated that he was progressing well in terms of accomplishing developmental tasks and building on those accomplishments. He was entering the toddler stage proper, with its inherent need to show himself to be a separate person, which he evidenced by wanting to do it himself. The foods that he was able to manage at this time were generally mastered by this age, but his early feeding difficulties had not supported his chance to learn to eat them. As a practitioner within the early intervention system, I made home visits to observe the parent and child interactions around feeding. This is what I observed that helped me determine Joseph's feeding capabilities were in this 5 to 7 month old range. And you have this as a PDF. I believe Ellyn's going to bring it into view for us. But it is...
I believe I am. Let me see. There it is. There it is.
There it is. I'll point out to you also that it is pages 250 and 251 if you have Child of Mine. And this is what I was looking at. If you look back at the slide, you'll see that Joseph was able to do all of these things, and that put his capabilities in the 5 to 7 month range. The manner of feeding was consistent with what he was able to do.
Okay, you done?
I'm done. Thank you, ma'am. At my assessment, Joseph weighed 17 pounds and 3 ounces. My assessment of his calorie needs was based on a formula, 102 kilocalories per kilogram of body weight, and so that came out to be about 797 calories per day. Now we always add in a margin of error, minus 20% of that 797 and plus 20% of that 797. So that's how I came up with this number, estimating what Joseph's needs were. The important factor here is to notice that most of his calorie needs were being taken care of by his G-tube feedings. And yet, Joseph shows interest in eating, especially when his mother feeds him. As Ellyn said, parents can't observe themselves, so I always timed my assessment for a feeding time so I could observe firsthand. And from the standpoint of the feeding dynamics model, Joseph's mom is doing a great job of observing his cues and feeding him in a way that gave him a say in determining how much and even whether he would eat. There's one tip-off, however, that her concerns that he eat may well lead her to interfere with this tuned-in approach. She wants spoon feeding to be fun. We will see how that plays out later. Additionally, as you can imagine, she has feared for her child's ability to gain weight, indeed for his ability to live. Those fears can drive a parent to put pressure on feeding. So at the time of this nutrition assessment, she sees signs that Joseph can feed orally, and she wants that for him very much. But he's gaining weight consistently for the very first time. How ready can he be to eat by mouth when his calorie needs are being met by a formula, mostly through G-tube? I don't have to tell you about the courage that parents of special needs children exhibit as they consider how they can best support their child, developmentally, nutritionally, emotionally, and socially. Eating has an important role to play in each of those areas. So to summarize my impressions, the shortness of breath that Joseph experienced during his early feeding compromised his capability to eat enough to grow well. Not until gastrostomy tube insertion was he able to recover a good rate of weight gain. Feeding by G-tube didn't tire him, and subsequently his oral nipple feeding was higher than ever. He was offered semi-solid foods twice a day, which is stage appropriate with his feeding capabilities. Now both parents are present and involved. During Joseph's early months, he dealt with his heart condition, multiple infections, multiple feeding methods. His parents met with cardiologists, pulmonologists, gastroenterologists, and developmental pediatricians. His medical condition has stabilized, but more procedures are in his future. His mom is able to verbalize her concerns, and currently her main concern is that he increase his oral intake. She understandably worries about compromising his weight gain and medical stability, and she's the primary caregiver. Father travels a lot, but he's in good touch with the family. Now, while the feeding skills are assessed at 5 to 7 months, developmentally he is showing early signs of separation individuation, as evidenced by grabbing the spoon and bringing it to his mouth. He clearly would love to do it himself, but he doesn't yet have the dexterity to do so. Joseph's mom is tuned in during feeding. She observes him closely and responds quickly to his cues. During bottle feeding, she strives to make him comfortable and easy. She stops feeding when she notices him tiring, but she offers him the bottle again so that he is the one to determine when to stop feeding. She's equally tuned in during spoon feeding, but her concern that he eat more orally leads her to try to advance his feeding skills by making feeding fun. Being too entertaining while feeding actually distracts children from their own internal cues, which drive eating, and will slow the natural process instead of hasten it. Joseph's mom needs support to continue to follow his lead and trust him to move himself forward. Her job is to provide the eating environment that supports him in doing so. The extent to which the parents are able to do their jobs of feeding and then trust the child to do his jobs of eating determines the level of intervention. Joseph's case is secondary intervention. His mom is tuned in and able to follow Joseph's lead with nipple feeding. But now she confronts the challenge of transitioning Joseph's calorie intake from mostly G-tube feedings to mostly oral feedings. Transitions are hard anyway. Add to it the challenges of the medically fragile child, and we can all understand how easy it is for concerns that he eat more orally result in trying to manage a child's eating instead of trusting him to move forward in his own time. So, I recommended nutrition services 2 times a month. I actually had to fight to get it 2 times a month, but I had a great service coordinator, and we did that together. The reasons for that was I needed to support mom and also the child care staff in maintaining a positive feeding relationship while advancing Joseph in the most stage-appropriate manner that he could manage. I also included monthly growth measurement on the same instruments to monitor growth and keep in touch with the doctor about the growth. I advised about food selection options which would match both his nutritional needs and match those to his feeding capabilities. But by far, the most important feeding dynamics recommendation I gave was to time Joseph's eating to when mom is eating. The division of responsibility makes concrete for parents exactly what their jobs are and what jobs they must leave to the child in order to support them developmentally. Again, we are transitioning. We are going from the infant division of responsibility to the toddler division of responsibility, bringing Joseph to the family table and having the parent take on the added responsibilities of when and where he is fed. The treatment plan is to provide an environment that lets Joseph learn how to eat. To do that, we must decrease G-tube feedings to allow him to be hungry. In establishing the division of responsibility, we worked on the following bullet points, and then we adjusted the G-tube feedings as warranted. Mom planned her meals to fit Joseph's feeding times. She also sat with him during snack times. She modified foods that she was eating to fit Joseph's mouth skills. No more coaxing or playing games to entice him to eat. Playing games to get Joseph to eat, which was happening at childcare as well, distracts Joseph from recognizing hunger and eating in response to it. It shifts his attention from his internal environment of experientially learning about self to eating to please others. Children's normal eating behaviors often appear to adults to be food rejection, but they're not. All children, Joseph included, are normally erratic in their eating much more sometimes than others, eating only a few items offered as opposed to some of everything, and turning down even seemingly favorite foods. Joseph had jobs too. I'll let you read through them. The way his mom and I approached our work together was to time my visits to an eating time. We would all eat together. All the food would be on the table. Mom put items on Joseph's tray, and as she and I ate, we also observed Joseph from the corner of our eyes, giving him his space. We discussed what had happened in the intervening weeks since my last visit and drew conclusions about his progress and how to support it. Joseph, as every child, sampled foods by looking at them, touching them, putting them in his mouth, and taking them out again. He did this over several months without swallowing a bite. But that is called food acceptance skills, or sneaking up on new food and learning to like it. It is movement along a continuum, and it is very helpful for parents to recognize it as such. Between 12 months and 15 months, Joseph gained 6.3 ounces per month. G-Tube's schedule now revolved around meals and reduced from 27 calories per ounce to 24 calories per ounce. He took his bottle in the high chair, trying to hold it himself, but with help from Mom as needed. He explored many textures by taking them to mouth, but ate mostly smooth or crunchy. And how many times have you found those to be the preferred textures? Our mantra became, serve a variety, even when he isn't eating a variety. Working with this population, I am sure you have experienced the inevitable interruptions caused by hospitalizations. Joseph's gains in weight and eating were interrupted by illness, multiple ear infections, restrictive lung disease, finally pneumonia. For an entire month, his oral intake was depressed. Then he was put on Pediasure, which he did not tolerate well. Continued difficulties with Pediasure led us to mix it with the Lippel that he had been receiving, and slowly toleration grew again. Our focus was on supporting him nutritionally with G-Tube and bottle and continuing to give him opportunities at mealtimes to explore textures. He went for smooth almost exclusively at this time, but was offered all textures within the context of the family meal. We discussed new foods to try at our meal times together, and this is when we started offering butter balls. As his strength increased, so did his ability to hold his bottle at meals and his interest in trying new foods. His mother supported him by giving him 6, sometimes 7 times to eat each day, with 2 to 3 hours in between. He no longer needed help from Mom to hold the bottle, and his intake increased. He began using a sippy cup at meals. He began picking up crumbs with a pincer grasp. He ate lumps mixed into a smooth texture. He ate buttered toast strips and butter balls. He taught me that oftentimes children go through long periods of not doing, and then all of a sudden they do everything you've been working on and exceptionally well. During this period, a speech therapist was added to the team. Joseph tolerated lip and cheek stretches and even let her feed him. We discussed the advantages of sippy cup versus open cup, straws to build cheek muscle strength, and tongue lateralization. Between 18 and 20 months, we experimented with decreasing the G-tube, and Mom had a slip in terms of the division of responsibility. She started putting pressure on Joseph's eating. We were getting so close to oral intake being able to account for most of his intake, and she, or perhaps someone in the medical setting or on the team, thought the process could be hurried. She started short order cooking for Joseph, trying food after food at mealtime so that he would eat something instead of just letting him pick and choose from what she was eating. And of course, Joseph, as any self-respecting toddler, took her on a merry chase to discover the perfect food. You've seen this slide before. I bring it back now to emphasize the point that the pressure felt to increase oral intake led to that short order cooking, which made available food after food to try to get him to eat. Now, how does short order cooking pressure the child's eating? Well, do you think that Joseph knew it was important to his caregivers that he eat? As a toddler, working on separation individuation, to experience himself as separate, he had to counter the pressure to eat by not eating. Now, once she stopped letting him control the menu, which of course is her job, things went better. And by 20 months, the G-tube during the day was a thing of the past. Joseph's mom was ready to experiment with decreasing nightly feeds. As she did this, she noticed his butterball consumption increasing. "He's eating butter by the handful," she announced as I arrived one day. Well, he was showing his ability to self-regulate intake. As you can see, his weight gain was continuing to be consistent, and the calories from butterballs helped to compensate for the loss in formula calories. Over the course of several months, nightly G-tube intake decreased. It was up and down depending upon weight gain and mom's concerns and Joseph's health issues. But Joseph was amazing us with the things he could do. I had encouraged mom to cut grapes into quarters to decrease the choking risk, but she reported that Joseph kept reaching for a whole grape, so she gave him one. He moved that whole grape around in his mouth, keeping it forward on his tongue until he could break it open and get the juice out. Then he spat out the flattened peel. Truly, he had devised his own tongue exercises. We gradually came to the place where nightly G-tube feedings were optional. Mom determined the need based on how well he had eaten during the day. As you can see, weight gain was proceeding in a consistent manner, and all of his doctors were pleased. Joseph was truly asserting himself, showing us all that he was his own little person and the one to call his own eating shots. The speech therapist notes in her quarterly report at this time that, quote, "Mom and I have discussed his eating issues in depth. It appears as though part of the issue was control. We have noted that he would try things when he didn't think others were watching him." This speech therapist and I worked together on another case later, and I was very happy for the collaboration. She could see the benefits of eating with the family and allowing the mother to take the lead with feeding. I will never forget the day that I arrived at the house to an excited cry from Joseph's mom. "You won't believe it. Come sit down and join us." And there he was, happily eating corn on the cob. "Hi, Pim," he said, and pointed to an outside window where a dog was playing. "See, dog?" To Joseph, this was a very matter-of-fact happening. His mom and I did the very best we could to be matter-of-fact, too. By this time, the PT had discharged and speech had decreased. Joseph had gained 6 ounces in 26 days on oral feeding alone. His growth continued to be consistent, his weight for length following along the 50th percentile. At discharge, he was having 1 bottle before bed and drinking from a sippy cup at all meals. He was adding more meats to the variety of foods that he enjoyed. The last comment in my discharge from nutrition services read, quote, "He is not only a very good eater, but quite an engaging conversationalist. Family meals are always fun." In my 6 years of working with the early intervention program, I met many children who have been labeled as resistant eaters. They may have had medical conditions or been born prematurely. Others simply manifested delays for which no diagnosis had been made. Concerns about growth, development, even survival had taken center stage, and when the emergency was over, the child and parent were left with figuring out feeding and eating. Children seem to be incapable of eating the amounts they need to grow well. They seem to lack interest or enthusiasm for food and seem to have no desire to learn to eat new foods. Working with these families to provide children with a feeding environment that allows their buried capabilities to resurface is what a feeding dynamics approach is. I can tell you that the first time I did it, I wondered if it would work. But that changed, and the only question became how long it would take. I learned through experience that it works. I also learned that patience is required. No one can predict how long it will take for enough trust to develop so that a child begins to explore on his own and learn to trust information coming from himself. Learning that you are capable often requires someone else trusting that you are. And that's the thing that these three children pictured here had in common. Parents who decided to do their feeding jobs and then trust their children to do their eating jobs. One responded immediately, and I worked with the family for less than 3 months. The other two took far longer, but they both brought themselves along, and you got to hear about Joseph's journey. They absolutely couldn't have done it without parents who trusted that they would. If you want to get deeper into this subject, here is where to go. The book Child of Mine covers feeding according to the division of responsibility for the child 0 to 5 years of age. And Ellyn's DVD set, Feeding with Love and Good Sense 2, which Carol Danaher, our introducer, had a lot to do with, features real parents and children at every stage of development as they interact at mealtimes. I sometimes would take a DVD or a VHS to watch with a parent at my ongoing visits, because sometimes when you watch someone else, you find yourself there and you're able to see and understand the child's reaction to what you are doing far better. Both of these can be found on Ellyn's website. So now we've come to time for questions. I want to reassure you, first of all, that if we don't get all of your questions answered today, there is an opportunity for them to be answered at a later time. Actually, tomorrow we're going to be offering a forum, an online forum, it's going to be entitled Clinical Issues Related to Applying Eating Competence and Feeding Dynamics Models. And as a participant, you'll receive a link to that. I think that Ellyn is showing you what it's going to look like. You also want to be aware that Ellyn has a Facebook page, so you can befriend her. But here is what that board was. Well, there it was. Sorry, Ellyn. There it was. There it goes.
My Facebook page. Pam, I'm being your accompanist.
You totally are.
Page. These parents write in with the most interesting issues, and so I really enjoy it. And here is the clinical bulletin board that I put up and took back down again almost instantaneously. But this is easy. All you do is click on here, and you put in new topic, and you write in what you want to say, and then you just write, and then you submit. Oh, it's chastening me. But anyway, there it is. And so that's it.
You'll receive a link. You'll receive a link tomorrow to be a part of that if you would so like. And then you also want to remember we've got 2 more sessions coming up, and we hope that we'll see you then, and that you'll have another opportunity to get questions answered. So I know you have a chance to type in, so I'm going to see if I can read the font.
Well, this is really silly. Is that how you have to read it? It's just really tiny.
Let's see. Oh my gosh, I got to scroll all the way up here. You can tell I'm new at this. I wonder if I can expand this. Oh, let me try this. Wow. Okay.
This is not very friendly, is it?
No. Let's see.
What does that say? Remove this line. Oh, I think I probably edited that question.
If it would be helpful to you guys, I can read too.
Yes,
would you like me to read the question?
Yeah.
Okay. Kristen asks, when we reduce tube feeds, do you recommend reducing volume of the tube feeds or reducing calories per ounce? Thank you.
Well, as you saw, we started first with reducing calories per ounce with Joseph, and that was a pretty simple decision to make because it was already concentrated to a larger degree than would normally be. So if that's the case, I would definitely start there. And then as far as the volume, the parent is your best friend with that and their observations. Following along with, it's a balance of keeping the parent's concerns in mind and the child's growth, and so decreasing and then seeing what happens. And having the nightly G-tube feed was very helpful for Joseph's mom because if oral feeding didn't go well during a day, she had that option, and that made her feel better.
So it really decreased the pressure, or helped her not to put pressure on him to eat.
Exactly. And, that even with the non-G-tube fed child, I've noticed that same concept can work to help parents not pressure their children during meals if they always provide a substantial nighttime snack. Then that helps to relieve them that they've done everything they can do.
Oh.
So concentration first, and then I think you look at the ounces.
Okay, Cleo, I think we're depending on you.
Okay. I'll give you, Erin has two questions. I'm going to give you the easiest questions first. Are butter balls literally just balls of butter?
Yes, they are. As you know, I have offered this to so many, and children universally like them, and of course they manage them very easily because they just melt in the mouth. Oh.
Okay.
So Pam, I'm going to challenge you on that a little bit. I know that Joseph was, was this diluting out the nutritional quality of Joseph's diet?
Oh, was it?
Yeah, with all that butter.
Oh, good heavens. It was adding to the calories, which was the very first need he had. And so in that regard, it was, maintaining what needed to be maintained, and then he was able, from that more stable state, to look around for something else.
Okay.
Okay, and the second of Erin's questions are, what are your recommendations in communicating with medical care professionals working with your patient? I feel like doctors' recommendations and pressure undermine what progress I'm trying to make with the family following the feeding dynamics model. Are there specific forms or documentation that you have found helpful?
Oh, that's a great question. Well, of course, within my state's early intervention system, there were forms that I used. I would always fax over the signed release saying that I could view the medical records and the growth chart, and then I also would indicate that I would send my quarterly reports and my 6-month report, et cetera, and I always did that. And when I would fax it back, give all of my information for how they could get in touch with me. Sometimes I would call and ask to set up a time that I could talk with the doctor about the progress that I was seeing. But keeping the steady flow of information going, and then also talking to the parents about what they're hearing from the doctor and what they're hearing from me, and if there's any inconsistency in how they're feeling about that. And so you really use many different avenues of communication to get to the doctor as best you can, because yeah, it can be an uphill battle. With some, it's a steeper hill than others, but if the parent is engaged and seeing results, then that is your best testament.
Okay. Are we ready for the next question?
Yep.
How do you handle the child who does not have a G-tube and is low weight for trying feeding dynamics?
Well, then it becomes actually the same. We use the same model in terms of eating with the child, providing that structure. As you noticed, Joseph's mom offered 6 to sometimes 7 times a day, offering food, 2 to 3 hours in between, sitting with the child, having a variety of foods show up, and then a variety of textures would be included in that, a variety of fat contents. And one of the things that I often came across with the underweight child was Pediasure being used quite a bit, and so that was something that we also incorporated into the structure, that there would be, say, Pediasure offered at snacks along with, some solid foods. And then having the parent trust the child to bring himself along with all of that support. And I would highly recommend timing visits to a feeding so you can see what's going on, if that is something that you are able to do. I think Ines might talk about videotapes, and that's another way. I know that Ellyn has utilized those. But
I'd like to chime in here too, Pam, and that is,
great.
Is the child, it's what I said earlier during the assessment, if you are being made responsible for keeping the child alive or being made responsible for getting the child to gain weight, then you're dead in the water. You really, because in order to do that, you're going to end up putting pressure on feeding, and putting pressure on feeding is going to keep the child from eating. And so the issue of keeping the child alive or getting the child to be heavier than he is has to be dealt with separately. I mean, am I saying that properly, Pam? Because you certainly you dealt with the issue of growth with Joseph, but nobody told you had to get this child to grow faster. You were simply addressing his food intake and working towards stabilizing his growth.
Right. And, of course, you have hit on the most important piece, that you have to make sure that the child is stable and has the nutritional reserves so that when you put the structure in place and the parent is working not to pressure the feeding, that if he doesn't eat, it's not going to be, medically compromising. And so certainly you have to make sure that that's in place. But many, many times I had individuals that that was not a problem. Well, here we go. That's another opportunity to talk to the doctor and talk about what the doctor sees in terms of the medical stability, and if it would be okay, if it would be something that he felt that the child could withstand. And I had many times where, low-weight children, but they were able to eat within that context because it didn't take that long before they just started eating once the pressure was off. It could be a matter of weeks, 1 to 2 weeks.
Yeah, the very worst thing that could ever happen to a child, and I don't think it happens anymore. Back in the olden days, it used to a lot, that the child's tube would be pulled as a sort of prerequisite to getting the child to eat. And so the nutritional support would be taken away, and suddenly you have this catastrophe. The child had to eat or he would die. So I think we answered that.
Okay, and here's kind of a process or a procedure question. If you are in an office, would you suggest family bringing in snacks for observation?
I think that's a good idea. You know, it's, as Ines will be telling you, it's always useful to have the video, whether it's in the office or, you know, some offices loan families an inexpensive video camera that they can bring in videos, because that allows the parent to sit with you and observe themselves. But if what you have is a snack in your office and that's all you're going to get, and that sure is a lot better than nothing at all.
I agree.
Okay. It's right at 2 o'clock. Do you want to do another question, or shall we wrap up?
Let's wrap up. A deal's a deal, and we don't want to keep them any longer from their afternoon.
Well,
Pam, may I take just 1 minute, just a few
Sure.
seconds? I did see several questions asking about handouts. You can go to www.ellensaterinstitute.org. You'll see webinars and then webinar handouts, and I will email you all with a link to that as well. So, you know, don't feel like you have to remember that now, but if you're anxious to get to it, that's where you find it. Also, people have asked if we are going to be recording and archiving the webinars. We are recording, and you're going to need to give me a couple days, but I will get them on the website right where Ellyn is showing you. So under the webinar tab, I will put the recordings of the sessions there. So thank you, Pam, for giving me that minute to do some housekeeping, and I will turn it back over to you.
You are more than welcome. So, well, all that remains is for us to thank you, the audience, and I need to remind you that the completion certificate will come after the last webinar, which is